We are going to jump to questions. So if you have a question, please enter it in the question box. We will take the time to answer every single question. And the first one is, what is available to Ohio providers for specialized registry reporting?
That is, as we understand it right now, it's the cancer registry reporting, but we've asked CMS or ODH for clarification on that. And as I said, we're not sure whether the ORS reporting would be covered or not. You'll just have to stay tuned, and we'll hold a webinar on that as soon as ODH makes it available.
Next question is for secure messaging. We already had the capability last year, so what do we need to have for an auditing purpose for this measure? We have patients already sending us secure messages to the EHR. Now, I can tell you what I would personally do were I out there, in your shoes. I would take a screenshot of creating a message from the portal and then grab a screenshot of that being received in your EHR. I would supplement that with a meaningful use report that shows that a patient had sent a message. Honestly, probably if you've got a meaningful use report where a provider had received a secure message, that's probably proof enough. I would just go the extra step and grab a few screenshots.
Okay.
All right, next question is...
Measure protect patient health info. Language has changed to now include implement security updates as necessary and correctly identify security deficiencies. Right. Can you, must be completed. No. A couple of things about the security review. I don't know, do we mention encryption? You have to be encrypted.
Yeah, there's a brief mention of encryption in the rule. They don't really get into specifically what should be encrypted, but the rule is, you encrypt data at rest and data in transmission. Also, with your security rule, the deficiencies. Now, you get into the deficiencies and you ask 10 people the same question, you're going to get the same answer or different answers, but here's my interpretation of it, is that you have to have a plan to address all of the deficiencies. Right. The brutal reality is there will be some deficiencies that the organization deems as an acceptable risk, so the plan to mitigate that may be years down the road. Keep a list updated of all of the items that you've identified as deficiencies with a proposed date of resolution, the actual date of resolution, and if it was resolved, what you did specifically to mitigate that risk. If you have that living document with your security review, you'll be fine.
Yeah, and don't forget that starting this past year, when you get audited, they no longer just ask you for that year's security audit. They ask you for the prior years for that very reason. They want to see whether you've mitigated your risk, and if you weren't able to finalize stuff, how your timeline has changed. So look from one year to the next yourself when you are working on this.
We get multiple questions about will you receive a copy of the slides? The answer is absolutely. All right. If an organization has 6 EPs, do you have to have the same attestation reporting period for each provider?
No. You pick it according to which 90 days they meet it. The only thing you want to make sure is that your privacy and security is done before you attest for anybody.
Yeah.
Or that you have to attest for your first person has to have that privacy and security done.
If a provider is planning on conducting their security risk analysis in November, can their 90-day reporting period be prior to November? Absolutely. The security review must be complete prior to attestation and can occur outside of the 90-day reporting period, just so long as it was no earlier than the beginning of the calendar year.
Yeah, and the CMS specifically went into this in the reg because it had originally been addressed in an FAQ about a year ago. And they said basically they see this as an annual type of update, and so they're less interested in whether you're within the reporting period and more interested whether you're getting it within the calendar year.
Okay, the next question says, do you have to keep a binder for all your PHI? Now, I'm not specifically sure what you're asking there, but one thing you do have to have in your security risk analysis is an inventory of all the systems within your meaningful use certification where PHI exists. And that includes applications and servers.
Okay, educational resources.
Yeah, can they be resources we've made up, or must they be purchased and printed from the system?
Must be from the system now.
The cert states that they must be identified by the EHR. That's the way the spec is written, is that the system specifies based on problems, allergies, and meds. It presents the list of potential educational material that you can provide to the patient. If you can build your own educational material within your EHR that then becomes identified through that process, then absolutely.
But you can't just do what you had been able to do in 2011, 2012, where you just handed something out and then checked a box to say that that was, you know, your patient education.
Okay, next question. Our ambulatory office passed syndromic data reporting, but we do not give immunizations. Report to the CDC or report to a cancer registry. How can we meet two public health reporting measures?
Syndromic, you check yes. Immunization and cancer registry, you would check exclusion. And when you take an exclusion under public health, be prepared to have like a sentence or two about why you think you're excluded. You know, we are, say, a dermatologist. We don't give immunizations. Cancer registry, we're not. Oncology, we're not participating in this. So that's all you really need is a very, very brief explanation as to why the exclusion pertains to your practice.
So the fact of the matter is you may not get to two, and that's okay if you have documentation supporting your exclusions. Cathy, you mentioned that a CQM reporting period needs to be any 90-day at a minimum. Does this mean that our CQM reporting period could be 365 days? Our vendor only allows us to run a report for the entire year.
Yes. The answer is yes. Pat, you can do 365, which I'm sure would help a lot of people who are doing PQRS. But keep in mind, if you're doing PQRS or ACO, we do not recommend that joint, I mean, personally, I know CMS recommends it, that joint filing of your CQMs. What we found this year is that people were waiting months and months and months for their incentive dollars because CMS has to process that as a part of the regular PQRS and quality reporting. So people weren't seeing incentive dollars until at the earliest midsummer. So keep that in mind. If you're concerned about getting incentive dollars in, I would just, at least for this year, go ahead and attest for them separately, but you can use the 365-day period.
And keep in mind that if you do use a 90-day reporting period for your CQMs, that 90-day period does not necessarily need to be the same as your meaningful use 90-day reporting period. All right, next question. Are psychiatrists excluded from syndromic surveillance? The answer is yes.
Yes, but again, you put down what your scope of practice is. The review manager meeting. They will be available today, and the cheat sheet is one long sheet, 2 sides, that has every measure, every exclusion in the year. So that should help you.
All right. Can you review the CDS criteria again? Absolutely. You need to have 5 clinical decision support rules that map to at least 4 CQMs across at least 3 of the CQM domains. What that means is you can have more. If you have 10 CDS rules that map to 9 CQMs across all 6 of the domains, great, but your minimum is a 543 rule, like it's kind of been with stage 2. Also, it is the expanded definition of a CDS. It's not just that pop-up that blinks in front of a provider that stops a workflow. It is now inclusive of documentation templates, clinical guidelines, problem-based order sets, the blue info button, integration, anything that you can deem that improves patient care.
Yeah, if you're primary care and you have order sets built for chronic conditions, for diabetes or hypertension or cardiac failure or something, those are all considered clinical decision support tools. So just think about how you're using your EHR. Think about how it supports your clinical workflow, and those are going to be your clinical decision supports.
And CMS has a really good tip sheet on the CDS rule that kind of even gives you a broader definition, but that CDS can present to registration, a nurse, the provider, your discharge staff, whoever, any place within the workflow. Okay, regarding secure messaging for 2017 at 5%. Does the message originate from the provider's end or the patient's end in order to count for this measure? Either one counts.
It originates from the provider's end in the sense that it's whether the provider, for tracking purposes, emails the patient. The email can either be initiated by the practice, or it can be in response to a patient's email to you. But it'll be that response that gets captured. And then this SRA tool, the reason the SRA tool, if you look back on our slides.
Yeah, the question is, could you explain the SRA tool and how does CMS know if it's completed?
If you get audited.
Yeah, honestly, that's it. They don't really know until you're audited. A lack of a security review or a review that doesn't meet the standards is still to this day the #1 reason that providers and hospitals fail a meaningful use audit. The SRA tool stands for Security Risk Analysis Tool. It's been recently updated by CMS and ONC. They have now a little application that you can enter all your information in, or they have these nice Word document templates that you can use. Originally, folks thought of the SRA tool as something that the small provider practices or independent provider practices would use, but they specifically say that this can even be the basis for large organizations for their security risk analysis. Now, I personally would not, I would personally recommend that health systems, large provider practices engage an outside entity to ensure that they're meeting the rule, but
you can do it either way. And when you get these slides, go to that page that talks about protecting patient information. And we built the link into it to the SRA tool, and that link appears in the rule itself. So click on that link and it'll take you directly to the SRA tool. There's a number of places you can find it, but that'll take you straight into the CMS site. And you can just browse through it and see what they're asking.
All right, next one's a long one. If a hospital meets immunization registry, syndromic surveillance, but is exempt from ELR, does that meet the measure of 3? If the hospital does currently submit to the Ohio Cancer Registry and the data is entered manually in the registry, does that count? Shouldn't it be submitted via HL7 interface? And
oh, you're so tricky.
Yeah, Debbie asked $1 million question here.
You know all the right questions to ask. Okay, the thing about exclusions is you can take an exclusion, but in order to take it, you have to show that you weren't eligible for any other measure. So in the physician world, since there's only 3 to choose from, if you take an exclusion, you only have to show that you weren't eligible for the 3rd measure either. On the hospital side, you know, the cancer registry is one of the questions. We just, you know, Deb, it's funny, we just sent this to ODH today. That very question about the hospitals reporting to the cancer registries and what the requirements are. And yes, I would say the cancer registry under the stage 2 regs would be an electronic 251 feed, but HL7, we will get clarification on that. If you're doing manual, whether that would count. I would say it wouldn't count, but we'll have to find out.
Yeah, there's some flaky language around that the submission of data can count if it's done via functions outside of the certified EHR technology, but it leaves it that vague. You know, running a report and manually submitting is technically a function outside of the certified EHR, but we're trying to get a little more information to see what counts.
So watch for our webinar on that. As soon as Brian's got the answer to the questions, he's promised us a webinar just strictly on public health reporting.
Does the 90-day reporting period have to match the 90-day volume period for Medicaid providers?
No. Medicaid, keep those as 2 totally separate concepts. Medicaid eligibility reports go back as long as almost 2 years ago. Because you're looking at eligibility as it was determined in the preceding reporting period and including the past 12 months. So your reporting period this year is 2015. So the preceding reporting period was 2014. So basically you're looking at any time from January 2014 through the end of 2015. You need to find a 3-month reporting period for physicians where they crossed 30% eligibility, or for EPs. On the hospital side, you go back to your preceding reporting period for 2014, actually began in October of 2013, and extends all the way to today. So it's a very long period for eligibility. Clearly, the meaningful use attestation report is only linked to this particular calendar year, or for a hospital with this exception this year to go back to October of 2014. But basically, Medicaid eligibility is always a longer look back than your meaningful use report.
Next question is, will there be another webinar? We do not currently have another webinar scheduled on this topic. We will be posting a recorded copy of this to the CliniSync YouTube page, so watch out there. Last question that we have, which I need to check chat, but last question we have in this feature is, if you are not an oncologist but treat cancer patients, example, general surgeon, can you take an exclusion for the cancer reporting registry? Now, there's really two parts of it to look at. Is number one, is your EHR certified to report cancer to cancer registries? Many EHRs are not. So if your EHR is not certified, then no, you can't do it. Now, the second is for cancer registry, you have to diagnose and treat. Really, a general surgeon's not doing the diagnosis. They are doing treatment, but I think that they would fall out from that.
Well, general surgeon, usually once it's diagnosed, they'll push it to an oncologist for treatment. So again, we'll push that to Brian and ask him to clarify that. You know, the cancer registry is not one that was widely used last year, but it's becoming more, people are more interested in it. What I'd heard ODH say last year is they were trying to limit it to true oncology centers, but I want them to put in writing exactly who would and would not submit, and then we'll let you know that.
Well, folks, that is our last question. We would like to thank you so much for attending. If you do have a question that we didn't answer, email Cathy or I, call us. We'll help you out.
And thank you so much. Enjoy this day, and we'll talk to you soon.